n'ubushakashatsi bakoze ku buzima bwo mu mutwe bw'abana ndetse n'ingimbi. Julia, you are most welcome in front to present. Thank you.
Good morning. Good morning, Maramotse. Nice to be here. Distinguished guests, esteemed colleagues, friends, representatives from the government of Rwanda, from University of Rwanda, all protocols observed. It's an honor and a privilege to address you at the National Trauma Symposium 2024. This gathering reflects a shared commitment to a deeply important cause. And today I'm going to focus us in a little bit onto the youngest part of that cause and talk about the mental health and well-being of Rwanda's children and adolescents. So let me begin by expressing my heartfelt gratitude to our partners. Because a lot of what I'm going to talk about today comes from a recent survey that we did together in a wonderful consortium between UNICEF, the Rwanda Biomedical Center, and the University of Rwanda. And that's two divisions at RBC, two departments at the university, and then UNICEF. So the leadership of these institutions continue to shape the landscape of mental health in Rwanda, and I want to commend them for their commitment and scientific rigor and visioning. So, and then thank you to all of you, because each of you will play a vital role in addressing challenges that our young people face, ensuring that, no child is left behind, as we say in UNICEF, in their journey towards health and opportunity. So mental health is a cornerstone of well-being, yet it remains one of the most stigmatized aspects of health, and that's true globally as well as in Rwanda. So these recent studies that I'm referring to, they reveal an urgent need to focus on our children and our adolescents. So let us not, I know we're talking a lot about the genocide against the Tutsis and reflecting on what this has done to our country. So I wanna focus us in on the youth here. So we're seeing, and these are preliminary unpublished results, that 18.9% of adolescents in Rwanda live with at least one mental health disorder. So depression and anxiety are definitely the most prevalent, affecting nearly 1 in 10 people. And I want to bring attention to who is most affected. So we see older adolescents, and especially females, disproportionately affected, as well as those in urban areas. So it turns out it can be a lot harder on mental health and well-being to live in urban areas. And among this 15 to 19-year-old age group, we're seeing that more than a quarter of females and 22% of males live with at least one mental health disorder. And because of the theme of the conference, I want to speak a little bit about intergenerational trauma, which I'm sure you have discussed in the last couple of days. This enduring legacy affects not only survivors, but also their children and grandchildren, manifesting in emotional distress, anxiety, and feelings of disconnection. The scars of this history underscore the need for targeted interventions for young people. In the case of the study I'm mentioning, we actually saw that having a parent convicted of genocide is one very significant risk factor for poor mental health. And the challenges go deeper. So only a quarter of adolescents with mental health issues seek professional help. Stigma remains a powerful barrier, with some families attributing mental illness to possession or curses still. There is also a troubling mismatch. So parents seem to be more likely to say that their children are receiving treatment, while the children will say they're not receiving treatment. So we're also seeing a disconnect in that story within families. So these realities highlight the gap between need and action, and this is something that I hope we can discuss a bit more and bridge together. So beyond individual experiences, as we know, mental health outcomes are shaped by a complex web of factors. We have family and community struggles, adolescents from single-parent households, or families affected by substance abuse and financial difficulties are at heightened risk. Experiences of violence, physical, emotional, sexual, or all, further compound their vulnerability. Educational and social disparities, adolescents not attending school or struggling academically show higher rates of mental health disorders. In fact, I sat in some community groups where really this pressure of school was a huge, huge risk factor. I mean, it was a huge reason that people cited for their mental health struggles. Conversely, school attendance serves a powerful protective factor. So if they can manage to stay in, it provides structure, peer support, and opportunities for growth. Then we have economic and geographic inequities. Urban adolescents I mentioned, and those in certain areas of the country, certain provinces such as North and West, report higher levels of depression and anxiety. And then, of course, rural areas will lack the access to of services and resources that our urban areas have. So despite these challenges, there are rays of hope. Families and communities remain central in the well-being of our children, and strengthening these support systems is part of the solution. We supported RBC on an child and adolescent mental health strategy, which hopefully shortly will be endorsed. And this strategy also reflects a lot of these strategies. So the strategy follows the principles of being child and family centered, of following a well-being continuum. It's not just about mental health, it's about well-being, being prevention focused, early intervention focused, and noting equity and access. So what should we do? Expanding mental health services. We must increase the culturally and age-appropriate mental health care. We're seeing gaps in skills and experience in growing conditions such as ADHD, autism, and psychosomatic disorders. So we see less support available for young people who are struggling with these less known mental health conditions. Leveraging schools as safe spaces. So I already spoke about how schools are uniquely positioned to protect and support adolescents. So we should focus on keeping young people in school, but also integrating mental health, not only education into the curriculum, but support. And that's why RBC, with support from UNICEF and other partners, has started a mental health program in at least 7 districts so far, which is soon to be expanded, where there are school counselors to provide this kind of support and strong linkages to health facilities. And then we have, of course, family and community support, strengthening family and community support. Families are the first line of defense. We must empower parents and caregivers with the tools to provide positive support, especially in single-parent households or those facing intergenerational trauma. As Professor Vincent said to me earlier today, which I wrote down, parenting matters. So UNICEF actually supported with National Child Development Agency a set of parenting guides, which are supposed to help parents along this journey. And we must remember that if parents themselves do not have a reasonable sense of self-efficacy, confidence, and well-being, their children also will not. Stigma. So the stigma issue is sticky. I feel that we've made some progress over the years, certainly since the landscape analysis from 2020 that UNICEF supported. I think we do see some changes, some raised awareness about mental health, but the stigma issue is sticky. So these continued community-based campaigns to dismantle harmful misconceptions about mental illness are critical. And we need to change it from mental health being a source of shame, but instead to a call of action for care and understanding. Early detection and intervention, which I mentioned from the strategy earlier. If we identify issues early, we can prevent long-term challenges. Routine screenings for younger adolescents and timely interventions are critical. So this is especially the case for vulnerable adolescents, adolescents who have been victims of GBV, adolescents who may come from other types of social economic hardships. That 10 to 14 age group is critical for prevention because we're seeing the higher rates in the older age groups. Let us give them the support they need socially before it turns into some kind of mental health illness. And then I want to mention multi-sectoral collaboration. And again, this comes out very strongly in the strategy that RBC has up for endorsement. So we need mental health to be a whole society approach, from health providers to educators to community leaders, but also to education centers, youth centers, and justice and rehabilitation centers. So I will wrap this up. I'll say as we conclude that, of course, that UNICEF upholds an unwavering commitment to the mental health and well-being to Rwanda's children and adolescents. We're starting a new country program next year, and I'm proud to say that we have an entire output on adolescent health, and a large focus of that is on mental health because we see it really as a linchpin for all other issues. You can link almost every issue into mental health. And so that's why I also want to say that this integrated care, this integrated approach is critical. We have to get out of the silos of SRH here and GBV here and mental health here and HIV there and livelihood, skills, empowerment, jobs. All of these things need to be linked together and they all come from different sectors. So we recognize that mental health challenges are deeply interconnected with the broader social, economic, and historical fabric of our society, and that's why we're committed to working alongside the government, our partners, and communities to create lasting solutions. So I'll leave you with this thought. Our young people are the heart of Rwanda's future. Their potential is boundless, but it depends on their ability to thrive. And that ability to thrive is not just physically, but mentally and emotionally as well. So let today's discussions inspire us to take bold, united action, and together we can transform the mental health landscape for Rwanda's youth and ensure a brighter, healthier future for all and a more prosperous Rwanda. So thank you so much for having me, and I wish you a fruitful day.
akoze cyane Julia ku bushakashatsi tugejejeho bwakozwe na UNICEF. Reka nsabe Professor Mutesa, umwarimu muri kaminuza y'u Rwanda, agiye kutugezaho ubushakashatsi bwakozwe bugaragaza uko uturemangingo dushobora kugira uruhare mu bijyanye n'uko umwana yakwandura ihungabana. Welcome Professor, and mufashe duha amashyi Professor ugiye kutugezaho.
Thank you very much. Actually, I have just to say that apologize for what I'm just going to share. For people who have been seeing this maybe several times, because this week I also have to present this study during the Genocide Prevention Conference which happens on Monday. So actually, it's an evidence of what's happened 3 decades ago, and then it's a scientific evidence that we are seeing that intergenerational transmission of PTSD and epigenetics, it's true. Here, what I want just to share today, there are a lot of traumatic events that can contribute to different component of PTSD. You see here different Holocaust events which happens in Armenia, Holocaust people, and what's happening in Gaza and other parts of the world, even now in Sudan. All of those, including the genocide of Rwanda, the genocide against the Tutsi in Rwanda, contribute to PTSD. So you know better than me what's the PTSD, the symptoms. What I want just to show you is that with this background, we know this country with this dark page since 1959 up to 1994 when the genocide happened. This left a country which was destroyed. This is just the story all of us we know, but with a lot of problems, mental health issues that we see the consequences even 3 decades later. However, when you live in this society, a society where you see there's a transformation, there's initiative just to for reconciliation, rapid social and economic transformation, infrastructure, education, empowerment of women, security, and you see the country today. So you can imagine how you live in a contradictory story. So from a background of genocide where people are traumatized, and those are the survivors that are having PTSD later. But you have a society like this one, how do you live in that society on the level of psychological perspective, but also biological. So biological, this is one of the talk today. So this just shows that with this evidence we have, where you see the PTSD in genocide survivors very high when you compare to general population, and even depression, which is one of the parts of the symptoms of the PTSD, very high when you compare to the general population. This is really a signal that something is happening here. So if there's no any support, psychological support, psychotherapy, so this, very well, this can lead even to the death. What we did, we started just with an evidence. At that time, almost 20 years ago, seeing that, of course, women who were traumatized, wisdom women from Avega Gaozo, which was one of our research group, target group, were having children born in that time, 1994, with dreams at a school. But during the commemoration, you see the different dreams from these children, to be a doctor, to be a lawyer, to be a teacher. However, every time during the commemoration, you were seeing some symptoms. They were having this kind of crisis, you remember? And sometimes during the outreach program for mental health division, but experts just trying to support these children. So there was those kind of assumption, maybe this is something that's not true. You remember? Yeah? During the crisis, the accumulation. Then this just was our initial research question to ask, is because these children, they were having the same symptom during that period, April to July, with different symptoms of depression, anxiety, and the others, like hallucination. Why we know these children were not directly exposed, were indirectly exposed because their mothers were pregnant. And then what happened, we had just our initial question at that time, asking ourselves if there could be any transmission. The transmission is you discuss on the PTSD symptoms. you just see symptoms being transmitted from one to another, from a generation to a generation. But on the biological level, that was just not clear at that time. But what we knew, environment can just contribute to contribute to destroy a little bit our DNA, and then that can just create some mutations. That was an evidence that we knew. And that will just define how you live in a society, how you live in an environment. And then, what we also knew at that time, the transmission of any event that a mother that just experienced during the pregnancy can also be affecting the children, the child, during the pregnancy. However, what we didn't know is, in our case, why these children are born in 1994 genocide are just having the symptoms. Well, we know they're not directly exposed. They are somehow protected. That was just our assumption. However, we want to dig deeper to understand if there has been any kind of something like a epigenetic defect that can just contribute to these symptoms. Just when you look at again, we zoom on the African continent, we see that African continent is very rich in terms of diversity. We have different diversity in terms of genetic makeup, in terms of language, in terms of physiognomy. However, what we don't know is just what's really not clear, not explored, is just the landscape on epigenetics. We even did a study, a review study, just very extensive to understand this mechanism, and then we saw that it was really not explored. In addition, when you see, just to make it really very simple for those who are not just in the field, this is a DNA, our DNA, which has an information. This DNA has some structure that will just predict what your behavior through the genes. The gene, when they express, they can just have a behavior. Either someone can have a behavior of just aggressivity, others will not, because the DNA may be genes that are more expressed than others. So this is what we see. So on a epigenetic mechanism, there is either some mechanisms that are normal, like development, aging. Those are normal mechanisms which are subject to epigenetic defect. When we are aging, our DNA just is subject to those damage. And then there are other conditions like a cancer, autoimmune disease, mental health disorders that happen due to the fact that the DNA can have some epigenetic defects, some mutations, and then this can just predict this disease to happen. What we didn't know is just the trauma, the war, the PTSD, the intermittent pattern violence, or other types of violence that can cause our damage of the DNA. And then, again, what you know, in our brain, we have this HPA axis, which has some components of some biological variations like cortisol. We know when we have, for example, trauma or stress, this cortisol variation will just be differentiating between someone who's stressed to another one who's not stressed. It will go up, and then during the acute trauma, and then we go down over time. And then that's what we see, even what we call the negative feedback. When these people have been traumatized, they tend just to have this biological variation. And even when we do the animal models, and then you test two animal models. In this case, for example, from this study, you see the mice, experimental mice, one expressing the symptoms of PTSD, another one just as a control model. You see the differences. So this was just an evidence in the humans, but I mean in animals. It has never been just tested again in the humans almost 15 years ago. And then some scientists like Professor Yehuda from Jewish population, actually she's a descendant of the Jewish Holocaust trauma survivors. she even predicted the effect of intergenerational transmission of epigenetics, even though that time in 2009, she could not just test, she didn't have enough tools just to test, but that assumption of predisposition or exposure to trauma which will be transmitted through the DNA was just predicted by this professor. And she even defined this transmission over generations, and even you see we leave our marks to our children. That's how the effect or term of the intergeneration is applied when you jump from one generation to second generation. And then when you start just to go further from generation to generation, then you start multi-generation and then transgenerations. Today what I'm discussing is this first intergeneration. So, and I will end up just showing you that we are now entering in next generation, which is trying to be now transgeneration. What does it mean? Those women who are traumatized that I showed you from the Avega Gauzo, and then their children born in 1994, second generation. Now we have children from the children. Those today who are 30 years old, they have their children now today. So what is going to happen? We are seeing some effect of transmission in these young children. And now, next please. Next, someone can assist. Okay, so what we did a pilot study. We took a sample, a small sample from those who have been exposed to 1994 genocide, the women, and then their children born in 1994, and then another sample size. Yes, this is what you see here. Those just who are living here in Rwanda, and those who are living outside of Rwanda, another sample size as a control. Next, and then we saw. Next slide, please. Yes, of course, this was our targeted group. Next, and we first defined the DSMB with DSMB, their symptoms clearly, with collaboration with psychologists, because remember we are dealing with a very sensitive group, so we needed just this psychological support before we can just allow them, having them participating in this study. Next, and then what we saw as a next, you can see the results here in red. Those are exposed for the PTSD. You see the results are very high. Next, when you compare to the mothers and the children who are not exposed, who are controlled. That was the first evidence. Next. And then, even when you go to the cortisol, you see the variations. So those who are exposed in black here, they have, after 20, that was almost 20 years later, in 2014, they had symptoms of cortisol very low level when you compare to the control group. Next, even other variations were happening for other markers that I mentioned for HPA axis, like a glucocorticoid and mineralocorticoid. You see here in the black, those are the mothers and the children who are exposed to 1994 genocide. Next, interestingly, again next, for the epigenetics, you see here the black. In black here, those are the high zones of epigenetic zones which are having the defects. Just those are called CPG in the DNA. You see when you compare to control group, they have a high level of methylation. Methylation, those are the damage of the DNA when you compare to that group. 20 years later. Next. And then we want to just after publishing this data 10 years ago, we want to go far. So the results as presented here, these are our last 10-year plus project. Next. We increased the sample size after just obtaining the support from NIH. Next. To see, continue next. Yes, to see the DNA methylation that I mentioned in a large group, large cohort of the traumatized people, and the control group. Next, also other biomarkers, and also the effect, the component of community engagement was really key in this context, to just make sure that we do this country-wide survey study just to come up with the clear picture for this. And then also we created a DNA biobank here, the first one in this context in the world. So next. Of course, with capacity building, so one of my PhD students just contributed, who just did this study, could just do the meta-analysis study to compare the PTSD, and again, the results were really very surprising to see the PTSD is still high in the survivor groups. Next. And you go to the next. With this, you can see the large cohort, same methodology approach. Those living in a country here, those are outside, with 450 cohort. That was really very good, just to give us a very good statistical power. So now, the findings I want to show you next. Yeah, okay, now you see we went to explore many genes here in the brain, many genes which are just in network for the different epigenetic components. More than 82 genes are explored in this context, just to see if you can have the power I mean, increase the significances for statistical power. Even with this the methodology, we could also make discordance to see the sex. You see on this picture, the males, for example, those are the children born after during 1994. But also, what I mentioned, I failed to mention, we also included the children who were born after 1994 genocide, the young siblings, to see if they received the same epigenetic defect. And then we come up with this first study from that bigger project, showing evidence of PTSD are correlated to high methylation. So you see here the methylation is very high in this group. So the more you approach between on the scale of 0 to 1, when you are just close to 1, that means you have high methylation. That means you have a high PTSD. When you are close to 0, that means so you have low methylation and the low PTSD symptoms. And then, can I have slide? Okay, thank you. Now you see the pink zones. Those from the 3 genes that we identified in this group. The pink zones, those are the zones of methylations in these genes, in this genome for this exposed group, women and their children exposed during 1994 genocide, and those were just born after 1994 genocide. That was really a very good outcome, evidence, scientific evidence. Even when you compare the genes, you see in the control group here in red, they are higher when you compare to the blue. Those are controlled. The level of methylation is low. And we identified several DMR. DMR means differential methylated regions. Those zones in the other component of genome that I showed for the brain, the genes. Several genes have been identified in exposed women versus non-exposed women. And even for the children, the same. 16 DMRs were exposed in the children exposed versus those who are not exposed. And even when you take these 3 genes that we identified as particularly for the first time in this group, traumatized group, you see the level of methylation is higher in the control, both children and the women, when you compare to those who are not exposed. And then the good outcome from this, we identified 6 genes that have never been characterized before, which are linked to some methylation, of course methylation that I showed, but also to expressed in a mental health components. So, and then when you have some mental health issues, conditions like anxiety, hallucination, like you see here, For example, the cognitive anxiety, those genes are expressed, and then these are really very good targets for the drug design. That means, for example, if you have been just treating those patients over time, maybe with drugs for depression, anxiety, and then there was no improvement because of there was a resistance. These are this is the cause, because these genes were not targeted. So we need to design the drug accordingly for the precision medicine. A very good outcome for next studies. And then I mentioned the community engagement was a key to engage this. Actually, we could just at least contribute also to bring some solution to these traumatized women you see here, to explain what was happening to their children. Yeah? Even though we did not just provide enough solutions, but at least we start to see some kind of resilience and also some kind of action to be taken, especially for children who are not having a good performance from the school due to this effect. For something that they were not expected to have if the genocide was not happening. So, and then this was our community. The community engagement component was really key. Just to finish, I want just to show you another implication of, remember the HPA, where you see the variation of the biological mechanism or markers. And also, when you compare the symptoms, here, for example, this is very interesting. You see the PTSD symptoms, here you see the exposed, they are very high when you compare to the controlled. For both women and the children exposed during the 1994 genocide. Even when you go to the, you compare this is a mother, this is first child, second child. Second child, those are children born after 1994 genocide. Again, you see the symptoms. They are still higher. You see in green when you compare to the normal, to the control in blue. This is a very good outcome, evidence to just explain this. And then on a biological level, when you look at here, there is an evidence of intergenerational transmission of this biological cortisol, glucocorticoid, mineralocorticoid in all groups, mothers, first children, first generation, and children born also from second generation. The young children, also the children born in 1994 genocide, showing the same transmission even 20 and 30 years later today. And good enough, here, when you see child 1, child 2, child 1, those are children born in 1994. Child 2, those are category of children after. You see they are trying to the children born after 1994 for the symptoms of PTSD, they are trying just to be better in terms of symptoms. There are some questions you can ask here. So when you compare to child 1, you see the symptoms are still high for the PTSD, but here they are trying just to be low. Why? Because they are born in a society which is really free of conflict, a safe society with a very good outcome in terms of resilience. This is just what's happening in the last 30 years. So this is one of the explanations. But you can imagine other contributors to this. And to finish, of course, we came up with this evidence last year just to publish this to show that what was predicted by the other professor Yehuda in 2009 now was just proven here. This was a proof of concept that there is intergenerational transmission of epigenetic defect for people who are just traumatized. And of course, with this study, we have been able just to address the capacity building. So we are even aiming to have, using what we created as a biobank and also the training we did to have at least at university a program just addressing this curriculum of epigenetic and intergenerational transmission. So this is ongoing work we are doing. And finally, there is also another work ongoing on cognitive neuroscience memory task, where we have been able just to come up with the Rwanda memory task tool this tool is just linked. It's like a Bible where you see different. I mean, a large component of the different words that we use in a psychological aspect, which are also related to cognitive components. And this one will just, we have a goal to measure the trauma-related mnemonic function and its association to PTSD outcome. So that means, for example, if you say something like machete for in a Rwandan context, for people who have been just exposed to trauma or to genocide, you relate. You can just relate this, the machete, to something. This is what we call the memory task. This is an ongoing study we are doing with Radboud University in Netherlands. This is what I mentioned as a future plans. So we are trying to develop this program, at least for the next generation of scientists who will be able just to understand over time what's happened here. And then with scientific evidence, and then we are pursuing our studies with other components to explore to these other studies like transcriptomics to understand the expression of genes and what could be just the prevention mechanism. I was just happy to discuss with Senate here just before starting this talk. How can we stop this? You know, we need some mechanism to be developed. And our future study, our current study, actually we got funded for this from a Wellcome Trust. I mentioned the generation 3. Those are the children who are being born now or who are just in this generation 3, born from the children born from 1994 genocide. So to see what's going to happen. So this is our next 5-year research project to address this. And we're also happy just to share this with the scientific community during the commemoration period this year. We can just have a full text in this Nature paper. And also we are happy just to see that even the international community recognize this, what's happening here, recognize this work. So this is just the Hugo Prize that was just awarded this year for this research program that we did, and which is ongoing project. And in conclusion, what I showed you from the pilot study was just a starting to address the simple question that we had almost 10 years ago. And we come up with a epigenome wide association to explore the whole genome to understand each zone of our genome, especially for those who are trauma survivors, to come up with some explanation of genes related to symptoms you see of PTSD symptoms, and then to make that clear, strong evidence of correlation. And I want to, it's a little multidisciplinary team that have been contributing, and we receive every day some call for collaborations because there are people who are just interested just to collaborate. But especially these are collaborators, but I want to thank, but also especially our funders. And thank you very much for your attention.
arakoze cyane Professor Mutesa. Hari impinduka gatoya kuri gahunda dufite, ndagira ngo mbaze nsabe Professor Mutesa ndetse na Julia bazi imbere dushobore kubabaza ibibazo, kubera ko Julia yagiye afite umwanya muto hamwe natwe. Julia, please welcome for questions.
Yeah, good morning. I'm Vincent, as it was said by the facilitator. One, I want to thank you to express my appreciation and gratitude. Gratitude for sharing the knowledge you have accumulated from the different research efforts, and on a particular and very sensitive group, the young generation. But also the information you are sharing with us is a proof of concept, as Professor Mutesa said. It means we are having evidences either that confirm what we sometimes allude to in the public conversation, where people say, oh, our children, our adolescents are not doing well. And then when you have data like what you share from the survey by UNICEF and colleagues, and then we say, oh, now we even have evidence from which we can say our youth, our children need more support. The other message is the adults of today are sharing and transmitting something to the next generation, which is a concerning information, and even giving us a task and an assignment to do today if we want to have adults and parents of tomorrow. We have to start with the children of today. How do you help me and maybe others to not leave your presentation, the take home from your two presentations, to not only be the concerns? What are the message of hope can we learn from your two presentations? Are we only expecting to transmit trauma? Is there any possibility of transmitting resilience plus? From UNICEF, what do you say about that difference seen between rural and urban? Because the data are showing difference between rural and urban young adolescents. What do you say also about the age difference? As they grow up, they are mostly to be vulnerable than the young. The youngers of today are becoming the adolescents of tomorrow. Can we expect to see such a vulnerability also doubling in the 5 years to come, or maybe a decrease? Anyway, globally, what message of hope can I take from to your presentation? The other thing was just to explain what my feeling. Anyway, thank you so much, and we hope to see the next steps. Thank you.
Arakoze Professor Vincent, reka dufate ibindi bibazo bibiri hanyuma tubaho umwanya wo gusubiza.
Murakoze. Nagira ngo nshime cyane ubushakashatsi bwakozwe na Professor Leon Mutesa n'abagenzi be. Hari ikintu gikomeye buri amwerekanye, ntabwo nyuma ya 1994 ntabwo ubufatanye bugaragara bw'umwakoresheje abaganga, abapsikologe n'abandi ntabwo bwagaragaraga, no mu myaka yakurikiye ntabwo byagaragaraga. Ubushakashatsi bwanyu rero burerekana ko bishoboka kandi ko ariyo nzira tugomba kujyamo. Igihugu cyacu hari amahame remezo kigenderaho ari mu Itegeko Nshinga mu ngingo ya 10. Hari ihame niryo risoza yandi mu mahame 6 yanditse muri iyo ngingo, ridusaba Abanyarwanda gushaka ibisubizo by'ibibazo biremereye igihugu binyuze mu biganiro bisesuye. Iyo havugwa ibiganiro bisesuye n'ibiganiro bisesuye ntabwo ari hagati y'abanyapolitiki n'abandi gusa, ariko ni hagati y'abashakashatsi. Iyo ibiganiro bisesuye rero hagati y'abashakashatsi, birumvikana ko atari abaganga ku ruhande rwabo n'abandi ku ruhande rwabo, mwerekanye ko ibyo ngibyo bishoboka. Kandi mwerekanye ko nanone iki kibazo murimo kutubwiraho ari ikibazo kiremereye igihugu. buriya hari igihe abantu batekereza ko ibibazo biremereye igihugu wenda bagatekereza ibibazo birebana n'umutekano gusa cyangwa se ibibazo ariko cyangwa mu buzima hakabamo ibibazo abantu bibaza ko ari byo biremereye igihugu wenda kuruta ibindi, ariko aha murerekana ko ikibazo kiremereye igihugu kandi kigomba guhabwa priorite. Bikanaba bigaragara ko ibyo muteganya mu minsi iri imbere bisaba ubushobozi buhambaye kubera ko ubushakashatsi burahenda. Bigomba kumvikana ko ubushakashatsi buhenda, bigatuma rero n'abatanga ubushobozi babyumva neza, binasobanura ko ubushakashatsi bukwiye gusobanurirwa abantu bose bafata ibyemezo kugira ngo ntibizabe ngombwa ko gusa ubushobozi mwebwe mu bushakira ahandi mu mahanga n'ahandi. Ngiye nkaba natekereza ko hashobora no kubaho n'ikigega cyihariye cyashyirwamo amafaranga kugira ngo mwene ubushakashatsi nabwo bufatwe nk'ubushakashatsi muri prioritaire kandi bukwiye kubona amafaranga ahagije kugira ngo bushoke, kuko biratugaragariza yuko ibyo professors baravugaga hashobora kubonekamo ibisubizo no mu rwego rwo gushaka imiti kuri ibi bibazo. N'izo laboratoire zikaba hano muri iki igihugu cyafashe gahunda yo gukora hub ikomeye mu rwego rwo gushaka ibisubizo mu rwego rw'ubuvuzi, n'iki kikajyamo. Wenda natinze kuri iryo jambo, ariko numvaga ari ngombwa kandi bikumvikana kandi n'itangazamakuru rikabyumva. Ikindi mbwira Mutesa, uzashake uburyo iyi presentation yawe unayishyira no mu kinyarwanda, mu magambo y'ikinyarwanda, kugira ngo n'itangazamakuru ribyumve, noneho bikore icyo kintu cy'ubuvugizi navugaga, kuko ubuvugizi bukora iyo n'itangazamakuru rikoze n'abashakashatsi. Ko rimwe na rimwe abashakashatsi bakoresha langaje nyine ihanitse ya gihanga, itumvwa n'abanyapolitiki bamwe na bamwe ntabwo bafite ubwo buhanga buhagije, kandi nibo barekura kashi n'abandi basanga. Hagati aho ngaho dukwiye kuzashaka uburyo mutabaha abashakashatsi mu bugenewe professors muri kaminuza, muri za laboratoire, ariko abanyarwanda bo ku zindi nzego bagire access. Ni nayo mpamvu tubavuga ngo byabaye byiza ko bamwe mu batanze presentation babikoze mu kinyarwanda, bitugaragariza ko bishoboka. Murakoze.
Moderator mbabare narimbwiye ngo ampe segonda imwe. Mutesa uze kugira icyo umbwira, watekereza gushyiraho ikigo cy'ubushakashatsi kuri trauma byaba bifite ishingiro, a National Trauma Research Center in Rwanda. What do you say about it?
Murakoze, reka duhe umwanya Julia abanze agire icyo avuga ku byababajijwe, hanyuma noneho duhe umwanya wisanzuye Professor Mutesa gusubiza no kugira icyo avuga ku byababajijwe. Turongera dutanga umwanya wo kubaza ibibazo. Julia, you are welcome to answer to the question of Professor Vincent.
Thank you so much. Yeah, so I'll answer the only question I could understand, and I'll leave the rest to my esteemed colleague. Yeah. Yes, and then actually I'll have to step out in a few minutes for another meeting, so could you let me go first? So really important points, because I think it's probably between the two presentations a little bit easy to get depressed ourselves, which we would like to avoid, given that we're here to support other people in that area. So I would say that the resilience point is a really good one, because when you go through hardship, that is how you build resilience. And we have people with too easy lives often will not build that. And I've definitely seen that in my own country, in the US. So I think we also have a lot of the foundations and like a lot of the family foundations. We have kind of that potential and the existence in many families of that kind of loving support and increasingly open communication that can simply make life easy. So if we communicate more with our children, we know it makes them better, and we have the tools to support parents to do this, and we have those, you know, in all different formats now. I think there's a lot of commitment. I mean, all the partners who are supporting this conference, for example, but the government, you know, from the highest levels, because of the importance of the genocide against the Tutsis and that event for the country, I think that you have a level of awareness and understanding in Rwanda about mental health that you don't have in many countries, and that goes from academia into government and back and through partners. So I have to say this is the first country I've worked in where I can really say that, and that will result in increased, you know, I think increased support from the highest levels of the government also. So I think we have a real potential to garner our efforts around this. If we do it right, if we get, you know, these strategies out there, we follow them, we plan them, and we follow them. In terms of rural versus urban, one other component that came out was about social media. And social media is a huge problem in a lot of countries, in the US, for example, where I'm from, and it came out here too. So this is actually not an issue of the future anymore for Rwanda, it's an issue of the present, and that's all the more pervasive in urban areas. I mean, people simply just have more access. So then they have this influx of all this different information, there's cyberbullying, there's everything that comes with that, and there's this idea that you need to live up, this social pressure to live up to be something that maybe you feel like you can't be. And I think that that is one of the reasons maybe for the urban-rural discrepancy. And I'm sure others could probably comment more on that. On the age difference, I mean, I think when you get to from 10 to 14 to 15 to 19, you start to face real life challenges. This is also when people hit walls at school often and end up dropping out. So the younger age groups, more of them are in school, more of them can see a future. But if you can't stay in school and you don't see what you're going to do with your life, and at the same time you're getting less parental support because your parents are looking at you and saying, okay, well, it's time you provide for yourself, or, you know, what are you going to do? Then I think that adds to the pressure, and you start to really think about, well, what will I do for my livelihood? How will I support a family? And so I think the point we made earlier, and one of the opportunities maybe, is to really intervene at that younger age group and to really have support systems in place for when support starts to drop off in more formalized areas of life. Obviously putting more into education, into improving the quality of education so that people are passing their exams so they can continue, and into the job creation, the livelihood component, the skills building, all of that. I think there's a lot of potential, and really, frankly, on that point, Rwanda's future depends on that kind of, I think, commitment for young people. So, thank you.
Thank you, Julia. I think she has another commitment now. We can release her. Arakoze cyane, reka duhe umwanya Professor Mutesa abanza asubize cyangwa agira icyo avuga ku byavuzwe.
Akoze cyane, reka mbivuge mu Kinyarwanda ko Professor Sezibera yanasabye kuyishyira presentation mu Kinyarwanda, ariko nashaka kubikora nuko dufite abantu wenda batumva Ikinyarwanda byari byiza, cyane cyane ko ibintu nk'ibi ngibi tuba dushaka no kubyereka abanyamahanga. Ari ibibazo Professor Sezibera yavuze na Honorable Senator Professor Sinyize Mungu yavuze bihura. Reka duhere ku kibazo cya hope. Cya hope ni kugira abantu batagenda basa nk'abakanzwe n'ubushakashatsi. Icyo nicyo kibazo Sezibera yabazaga. At least ikintu twerekanye nuko nanjye mbitangira nubwo nari nzi ko tuzabibona. numvaga ari ibintu bidashoboka ko twasomaga icyo gihe narigaga n'ibyo nigaga genetique ariko tugasoma tukabona naho muri Holocaust and the trauma survivors na evidence yari ihari nigeze kubyerekana aho hariya ariko at least ikibazo twari dufite cyo ariyo reality twari dufite mu gihugu nuko abo bana mu gihe cya genocide commemoration ya genocide mu kwezi kwa 4 kujya kwa 7 ndabyibuka twigaga i Butare ibigo byegereye by'amashuri aho ngaho Save na za Espanya n'ahandi Nyanza twagiyeyo muri outreach program za IGRG na IRG ugasanga abana barahamuka mu mashuri bakavuga ko ari byo bigira gira ngo mufite testimony kundusha abenshi byo muri trauma mental health program. So wanajya kureba performance mu mashuri ugasanga bari inyuma. So iyo niyo yari initially such question uko nabyerekanye almost 20 years ago nta n'ubushobozi dufite kubikora. So then later ubwo ubushobozi genda buboneka collaboration kumobilizing research grant ari nabyo gihurira icyo kibazo gihurirwaho na how do we niba hashobora kuba ikigega cyari cyo gufundinga research tuza kubona ubwo bushobozi byibuze bwo kubasha gukora gusubiza cya kibazo cya mbere. Noneho icyo cyafashije kugira ngo nerekane ko harimo hope yuko babana cya mbere cyo bamenye ikiri kubabaho n'ababyeyi cyane cyane ko nibo bari bahangayitse. Ubwo rero iyo bimaze kuboneka nabwo bivuga ko ibisubizo byose twabizanye at least hatangiye kuboneka psychotherapy psychologists batangiye kubafasha. Ushobora kurebamo some of the children icyo gihe ubu ngubu ni bakuru myaka 30 muri babandi nabavugaga ariko ba young siblings bari umuntu babo bavutse nyuma bafite nka 25 turabafitemo nabo muri izi group dukurikira usanga bamwe bari baragize ikibazo cyo guciciriza amashuri cyangwa se kudapasha guperforminga neza ariko muri za outreach programs za community engagement tubisobanura ugasanga ari cyo bibafashije even though hari tutarazana igisubizo cyo gukemura ka kantu naberetse ka epigenetic ka mutation kagiyemo ariko at least hari icyo bisobanura bikemuye. Again ikiza cya epigenetics and I need hope ntabwo iyo ufite na mutation ya epigenetics bivuga yuko necessarily igomba kugira ibimenyetso biza ari uko haje ikintu ki reactivating symptoms. Ni nayo mpamvu tubona muri aba bana bavutse after 1994 genocide bo they are doing well kuko bavutse muri society imeze neza nubwo bafite ka kantu ka epigenetics ariko bari at high risk haramutse hari trauma ibuvutse nk'ubu ngubu cyangwa ikintu kivumbura gituma hazamo stress bituma hazamo agahinda abambere bari exposed kuko bafite ya susceptibility ya kaka gene. Indi hope neberekanye ko for drug design harabo twari dufite bakurikiranwa kwa muganga ndabyibuka some of the psychiatrists b'icyo gihe barimo late Nason Professor Nason n'abandi nyuma bakurikiyeho nka Charles Mudenge n'abandi bakolege be they used to see this patient at the hospital especially in there bakabaha drugs for problems as depressions and sometimes no improvement kubera iki na improvement kubera ko the drug is not appropriate igomba kuba appropriate kuri ya mutation ya epigenetics nivuga ngo ibingibi birafungura imiryango for next research to identify the appropriate drug also solution therapeutic solutions for this type of population mu Rwanda. Ariko noneho ikiza ntago bigarukira gusa mu Rwanda kubera ko we all share the same genome twese duhuza genome ku isi nk'abantu nukuvuga ko even ahandi hantu barimo gukora ikibazo barikorerwa genocide DRC Sudan n'ahandi that means nabo bari kubona zi genes ziri traumatized solution twakuramo hano we serve the word you see bivuga ngo dufite rero isomo ryo kwigisha n'ahandi muri ibi bintu bya research twakoze hano. Ugiye rero ku bibazo senator yavugaga ibi byo turabyemeranyaho cyane n'ubwa mbere twari tubonye yuko byibuze okay so ubwa mbere wenda biragira ariko muri last 20 years collaboration between abantu bavuturuka mu bice bitandukanye abaganga aba psychologists n'aba sociologists twarabakoresheje cyane. Hari noneho nabo muri community engagement muri community abo twita community health workers cyangwa se abantu bakorana na muri community kuko niho dukorera cyane. So hakeneye rero gushyiramo imbaraga zo kubihuza niyo ya advocacy yari kenewe kubera ko ikindi nashaka kwerekana nuko mu biganiro bisesuye mwavugaga hagati y'abashakashatsi bigahoraho nibyo, ariko hari ikintu twatekereje, some of you hano muri audience hano barakizi, twanze gukora ikintu cyaba kimeze nubwo uzana initiative. Ni byiza ko duhuza ingufu twe gutatanya ingufu. Twakoranye dushaka gukorana na Minubumwe na Memorial Genocide Site like Gisozi, aho bashobora kubanza kuba bashyiramo. Murabona iyo mugiye tuvuge gusura site ku Gisozi, araho twinjira hano dusohokera, ariko ibyo wabonye usanga bikomeje kuba bimwe. Before genocide muri 59 ibi nibyo byabaye, during genocide nyuma dore byabaye, ariko ntabwo umenya niba hari abantu b'abashakashatsi cyangwa ibiniti bavutse muri iki gihugu bakoze ubushakashatsi bushobora kujya hariya. So twabahaye icyo gitekerezo cy'ukuntu tugomba gukora extension, hakaba habonekamo icyo bita research gallery exposure. Ubushakashatsi twakoze ntabwo ari twe twenyine, hari abakoze muri psychology, hari abakoze mu zindi aspect, ariko ntabwo bizwi. Uretse kuza kubivuga hano tukabidisipurayinga hano, ariko dukeneye ahantu bisigara nko kwiremba, ahantu binjirira. Impamvu uvuga kwiremba hariya nuko abanyamahanga baje mu Rwanda bashaka gukora genocide bajya ngubu buhari. So we are in, muri discussion to see how iki kintu cyabaho. None biri kuvuga ngo bizaba biri intergeneration, bizakomeza. We start with this research tuyishyira to displaying area, tunayishyira muri za ndimi Ikinyarwanda, Icyongereza, the largest spoken language here, ariko zina covering isi yose. Bahanyure babone take home message. Niba uvuze uti intergenerational transmission, epigenetics na PTSD, haba harimo utugambo dukeya tubasobanurira. Ntabwo nkeneye ko umuntu umucomplicating na DNA, no, hari uburyo dushobora kubisummarizing same ku bundi bushakashatsi. So ni zimwe muri zo twatanze some ideas. Abantu bakoze kuri anthropology, bakoze kuri history, bakoze kuri psychology, bakoze kuri forensic. Ngubu hari n'ubushakashatsi bwanakozwe during this period kuri forensic, how you can conserve the human body, the remains, igihe kirekire cy'imyaka nka 500. Nubwo bushakashatsi bwakozwe ntabwo buzwi kandi burahari, nko kuri site genocide site ya Nuza Murambi ni nk'urugero. So icyanyuma narangizaho, ndabona hakiri ibibazo byinshi muri audience, ni n'iki ngiki cya Professor Vincent Sezibera yavugaga ngo dushyireho na National Trauma Center Research Center. Ni byiza, ariko muribuka this week niba mwarakurikiye muri Genocide Prevention Conference, they launched the Research Center for Genocide Prevention. So I would later njyewe natanga icyerekezo kutakora duplication, ahubwo how we can have the synergy. Of course nakoze ubushakashatsi na my colleagues, but ntabwo ndi uwa mbere, ntabwo nzaba n'uwa nyuma. But we need some people also are having some research ideas to get together, also to strengthen the center yavutse ntidukore indi duplication, for example. So that needs ibyo senator yavugaga ubuvugizi, how this can, hari n'abantu bashobora kuba batabizi ko nk'icyo kigo cyavutse, ariko nukumenya kirakora gite, kirakorwamo nande, just for ku nyungu z'abantu bose b'abanyarwanda bari hano. So icyo nicyo narangirizaho. Ibibazo byose muri kwibaza hari ibyo nashobora gusubiza, kuko nanjye hari ibyo navumbuye simbibonera ibisubizo. Hari ibyo ntabonera ibisubizo ngiri gushakashaka. So nko kubaza ubonye nk'ikibazo kirimo kuri generation ya 3 tugiye kujyamo y'abana bavutse bari kuvuka kuri aba bana. Ejo bundi ubwo nanone twakora ikiganiro nk'icyaraho natanze urugero, bambaza bati se noneho nibiye bimenyetso turi kubona. Harimo nk'abana babiri mfite muri groupe ya survivors bakomoka kuri Avega women, trauma women, bafite abana babiri batoya bahuje kandi badahuye mu miryango, bafite ikibazo wenda cyo kuba bakomeza kunyara ku bibiri bafite imyaka 6-7. You see, that's a problem. Maybe ntago mfite igisubizo cyabyo, ariko se kubera iki muri category when you compare to burumva n'ibindi bibazo. So hari ibibazo byinshi bidashobora guhita bisubizwa muri iyi perspective.
Arakoze Professor Mutesa. Hari reka dufate ibindi bibazo bibiri gusa. hanyuma mutwihanganire kuko igihe kutugendana. Dr Yvonne, hanyuma nuriya uri inyuma.
Murakoze cyane. Ndashima cyane Professor Mutesa na Julia wa UNICEF baduhaye ibyavuye muri research. Icyo nshima kandi cyane cyane nuko nari ngiye kuvuga ngo ni ibisanzwe Leon n'umunyarwanda yatubwiye ukuntu yatangiye yibaza ari muri intervention, ariko ashishikajwe no gusobanukirwa no gukurikirana uburyo bwo gufasha, bwo gukontribuwa, bwo gutanga contribution ku kibazo ubona gikomeye. Kandi c'est vrai que abantu bose ntabwo umuntu yabashaga kumva abari bagize igihe umuntu agira ihungabana. Condition nuko umuntu aba yarahuye n'icyamuteye ihungabana. Abo bana umuntu wese yabonaga bimuyobeye akumva bidashoboka, niyo mpamvu bavuga ko ari ukwigirisha. Urumva we il est parti d'une question yibajije, ariko afite volonté yo gufasha. Natangiye mvuga nti kuri Leon ni ibisanzwe, ariko na Julia wa UNICEF nawe muri conclusion aratanga recommandation, akanatanga commitment ya UNICEF yo gufasha. Ntabwo ari ikibazo, ngewe nani ndashaka gutanga nk'inama, kuko ejo ntabwo nzaba mpari. Numvise ko hazashyirwa hamwe conclusion z'iyi Symposium, noneho hakazabaho no gukurikirana ishyirwa mu bikorwa by'ibyo abantu bazaba bumvikanye. Kuri ubushakashatsi bwakozwe ku bana na adolescent, ibyavuyemo ntabwo bitandukanye cyane n'ibyakozwe n'ubushakashatsi n'ibyo twabonye byakozwe n'abandi. Twese turumvikana, twagiye tunabona mu buzima bwa buri munsi ko abo bana ni abana tubana nabo, ni abacu, bafite ikibazo. Ababyeyi n'abandi banyarwanda ntabwo tumva neza icyo kibazo. Si ukutacyumva, wenda turanashaka no turifuza ko kitabaho, tukabura uko twifata, kuko tuba turi dépourvu, nta muti wabyo dufite. Yavuze ku kintu cya caregivers, parents, supportive behavior na mechanism. Hari inzego, nagira ngo nsabe bagenzi bacu bo muri RBC na Minisante, wenda hamwe na UNICEF, niba bitarakorwa dutekereze kuri abandi ba partners dufite mu gihugu ba UNICEF. Ndatekereza UN agencies, ndatekereza n'ama ministère, kuko abo bose bishize hamwe igisubizo ntabwo ari icya secteur imwe, ni secteur nyinshi. Kubera ko dufite UNICEF n'abandi, nibaza ko bishoboka ko dutekereza no kuri za forum dusanzwe dufite muri homegrown solutions, aho twanyuza. Ndatekereza ECDs, ariko nkatekereza n'ahandi aho ababyeyi bashobora gufashirizwa, kuko umuntu wa mbere chance dufite nuko umuntu wa mbere ukunda umubyeyi n'umwana. Ndumva bishoboka. Ibihugu byinshi by'isi cyane cyane bikiri mu nzira y'amajyambere, usanga santé mentale, mental health isigara inyuma cyane, kuko nta political will, nta volonté politique, nta gouvernance ihari. Hari n'ibindi bibazo nk'ibyo Professor Darius yatweretse, santé mentale idashoboka iyo ecosystem itubatse. Twe dufite imana ko santé mentale yakomeje gushyirwa muri priorité, dufite gouvernance imeze neza. Ibihugu byinshi bigenda bigira abapsychiatre gusa, umuganga w'abasazi nk'uko babita, hakabaho na hospital imwe, nk'uko nanone yatweretse ejo Professor Darius. Natwe twatangiye dufite ibitaro bya Ndera, dufite umuganga w'abasazi umwe ku gihugu, ariko ubu twaradecentralije. Kuba twaradecentralije, dufite amaservice, dufite n'aba psychologist dufite n'abandi kugeza no ku mujyanama w'ubuzima ufite ubumenyi mu gufasha iby'ibanze ufite ikibazo cyo mu mutwe. Iyo nayo ni force dufite ibindi bihugu bidafite. Nta budget ibaho muri mental health mu bindi bihugu byinshi byo ku isi, ariko twe dusigaye dufite buri mwaka nkeya dukurikije amikoro igihugu cyacu gifite. Iyo nayo ni opportunité tutashobora kwinyora. Icyari cyaradusigaje inyuma cyane n'ubushakashatsi n'abafasha n'abaza basanga igihugu muri gahunda yo kwita kuri problematique runaka baba bakeneye data. Dusigaye dufite data kandi dufite noneho aba scientist izo data bakoresha mu kuduha n'inama. Donc hasigaye gusa ishyirwa mu bikorwa. Ndagira ngo nongere nsabe nkurikije noneho ibyo twumvise Professor Mutesa ya de présence, hari ikintu cyo kumenya ko atari gusa counseling, atari gusa gutanga imiti dusanzwe dutanga, hariho na trauma zindi zihariye n'ibindi bibazo bikeneye noneho icyo yise precision medicine. Hakenewe labo, babivuze babisabye, kandi nibaza ko iyo willing nayo ndumva ihari, kuko hari nka village yose igiye kuba iy'ubuzima. Nibaza ko tugoze advocacy nta cyatubuza kwinjiza iyi thématique muri iyo gahunda. Hari synergy avuze Professor Leon, nanjye ndumva ndi d'accord nawe ko aho kugira ngo multiplier ibintu kandi moyen wenda tugomba kuzikoresha neza, numva niyajya kuri gahunda. Nanone ndasaba abagenzi bacu bo muri Minisante kugira ngo wenda tubibasabe mu ma conclusion azashyirwa hamwe ejo. Ntabwo biri impossible. Uwo muti wenda ntabwo turawumenya, ntabwo numvise bawuvuze, ariko mfite example ya clinique nshya yafunguwe muri Faisal. Darusi yarayivuze ariko sinibaza ko yayitinzeho, ni ketamine clinic. Ketamine clinic, ubushakashatsi bwatumye bimenyekana ko abana cyane cyane abajeune bafite ibibazo byo mu mutwe bisa nkaho byananiye abaganga, kandi tusigaye tubafite, bashobora kuvurwa n'uwo muti. Kandi uwo muti wari usanzwe ukoreshwa muri chirurgie, udahenze, uri deja kuri liste y'imiti yacu y'ibanze. Ubushakashatsi bwatumye bishoboka ko twawugerageza hano. Faisal yafashe iya mbere, yafunguye clinique nziza cyane. Abaganga bari bafite waiting list y'abana bananiwe gufashwa n'imiti, bananiwe gufashwa na intervention zari ubu barimo gufashwa. Kandi abashakashatsi nanone barongera bandike, bapublie kugira ngo baconvaincre abatanga amafaranga kugira ngo niyo ketamine clinic tuyigire hose, nk'uko twatangiye dufite consultation ahantu hamwe, dusigaye tuyifite ma district no ma centre de santé. Donc nibaza ko dufite terrain yacu iri favorable kugira ngo twakire innovations nk'izo ngizo, cyane cyane ko umunyarwanda niwe utugeza kuri ibi ngibi byose tugenda tugeraho. Yatweretse byiza, kandi les trois quarts la population ni abajeune, ni nabo bafite ibyo bibazo. Nibaza ko iyi symposium, d'une part ndasaba Professor Vincent izajya iba buri gihe, ariko nanone nk'uko yatangiye atubwira ngo ibyo twumvikanye, ibyo twasabwe 2019, tukerekana ibyo twatangiye. Hari ibyo tubona kubera ko byavuzwe icyo gihe byasabwe, n'ubu ngubu ibyaha ngaha tubikoreshe neza. Ndumva ndi optimist. Nafashe umwanya munini, murakoze.
Arakoze cyane Dr. Yvonne ku nyunganizi, ndetse no kuba ari mu bemeye ko bakora ubuvugizi muri gahunda zigiye zizakurikira zo kurushaho gukaza ubushakashatsi n'ibindi bikorwa bya sante mentale. Twemeye ko dufata ikibazo kimwe gusa, abandi muranyihanganira. Yego, ufite mikoro ya baza.
Murakoze, mwaramutse neza. Nitwa Ngabo Brave, mu nama y'igihugu y'urubyiruko. Ndishimye cyane ko turimo kuvuga ku rubyiruko. Nibyo nk'uko Dr. Yvonne yaramaze kubivuga, ni umubare munini w'abagize igihugu, ariko hari ba professors bombi bambanjirije bavuze bati ni gute twabyoroshya bikajya mu Kinyarwanda, ariko tukanoroshya imvugo y'abascientifique ikava ku y'abascientifique ikaba y'abaturage basanzwe b'urubyiruko. Hanyuma noneho ndimo gutekereza ku kintu kijyanye na, kuko kino gikorwa ni cyiza cyane, ni cyiza pe, ariko ntekereza ko umushakashatsi yakoze icyo yari akwiye gukora. Ubu igikurikiyeho ni awareness, ni ukugira ngo abantu dukora ubukangurambaga bukwiriye. Hanyuma habayeho kubyoroshya, tukoroshya kwa kundi Professor Leo yaramaze kubivuga ati muragakoresha terminologies zoroshye, twakora reflect, twakora application. Tunibuka ko turi muri digital world, ubwo ndagerageza kubihuza ikibazo dufite audience naho isigeze. Hanyuma tukabihuza ku buryo abantu bashobora kubyumva. Niba ari umuntu ashobora kujya kuri telefone akadownloading application iri buze kumufasha wenda gukora steps z'uko yiyumva, ese ubyutse wiyumva ute, ese kugira ngo umuntu agire na self evaluation, hanyuma tunamenye n'urugendo rwaho tuva naho tugana. Ntekereza yuko ibyo bikorwa nibigerwaho mukumva hari icyo twabafasha nk'urubyiruko, yaba muri Minisiteri y'Urubyiruko cyangwa inama y'igihugu y'urubyiruko, we are here and ready to support. Haba mu turere, haba kumanuka kugera aho dushobora kugera hose, hagakorwa ibikorwa nk'ibi ngibi, abantu babiri batatu bakaza bakadufasha kubisobanukirwa. Kuko ntekereza ko iyo abantu bazamuye ubukangurambaga no kwibonaho ikibazo utaruzi ko ufite, nabyo biradufasha. Icyanyuma soza, nagira ngo nibarize the know how. Ese birashoboka ko hari practices zibanze ziri basic abantu bakora? Hari ibyo dushobora kwikorera, twakwigishwa muri bya bindi tworoheje, hari ibyo tujya tubona birimo tuvuge therapeutical groups n'ibindi nk'ibyo. Kuko twongere twibuke yuko izi service nubwo zihara ahantu hose, ariko hari nuko zihenze, hakaba na stigma ibiri inyuma, kuko iyo nayo ntekereza ko abantu bakirwana nayo muri uru rugendo. Niba hari ibyo dushobora gusangizwa muri izo descente zazakorwa, izo awareness, iyo application, mbese n'uburyo bwo kugira ngo muri kwa gushaka ibisubizo Honorable Senator yavugaga nk'abanyarwanda, dukurikije research mwakoze, hakaba na recommendations na bikeya kuri level yo hasi abantu bashobora gutangira gukora kugira ngo tugire iyo collective consciousness. Murakoze cyane.
Arakoze. Yego, reka tumuhe umwanya Professor.
Iki kibazo ndabona ndi gisubizo nyenyene cyane kubera ko kiri multi sectorial. Wenda ndaha Professor Sezibera na Honorable Senator, ariko kubigendanye n'ubushakashatsi. Iyo Symposium mbona byabigize, urebe abantu bari muri audience ko bameze, n'abantu intellectuals. Ariko ubushakashatsi bwakorewe ko abantu batameze nkatwe, batari intellectuals, batagize n'amahirwe yo kuba bagera kuri iyi level dufite. So kandi nibo bakeneye kubimenya. Uretse twebwe ko twakoresha biriya community engagement, of course kuba bigenewe cyane, ariko muri community babamo n'abandi bakeneye kuba babimenya. So ngewe nka recommendation atanga muri outcomes zava muri iyi symposium, nuko wenda the next symposium yaba nk'umunsi umwe, akaba wenda yitwa outreach program yo kumara wenda nk'icyumweru tuzunguruka igihugu dukora izi awareness, ikaba ari outcome yagira na impact cyane muri community. Aho noneho uretse ibyo twakoze, mwageze kubona ko nsobanura wenda gakora PTSD symptoms, hari na prevalence, ariko izo ni studies zakozwe nyinshi zagiye zikorwa n'abandi baba psychologists, ariko nago zizwi mu rwego rwo hasi rwa community. Inkunga nziza uri gutanga yuko urubyiruko rwakoreshwa cyane cyane kugira ngo habeho iyo outreach program yo kugera hasi, ni byiza, ariko nawe kugira ngo bagire hagombye kubaho level TOT, training of trainers mbere yuko nawe ujya haze kugira ngo ugiye kubivuga wenda wowe wabanje kunyura muri ka training ko gusobanura epigenetics ibyo ari byo ibyavuyemo nawe bijyane hariya niko kuntu niba bishaka kugera ku byasakara vuba kurusha wenda umuntu umwe abikoze cyangwa tukabikora muri symposium nk'iyi nimwe muri contribution natangaga sinzi niba abandi ba expert hari icyo bakongeraho kunuza.
icyo navuga nuko ubu ngubu hari ikintu kiri something is happening now sibyo hari ikintu kirimo kubaho hari ubushake bw'urubyiruko no gufatanya n'abo bakuru babo b'abasaza n'abagize gute n'abandi ni ikintu cyiza cyane ahubwo biraryoshye mu by'ukuri biraryoshye ni ukuvuga ko abantu batandukanye baba bashakashatsi urubyiruko batangiye kumva bya bindi Dr. Yvonne yavugaga by'iki bya environment nziza igihugu cyashyizeho kuko hari igihe usanga igihugu gishyira mu bitekerezo byo hejuru gishyiraho conditions ariko abantu bakurikire icyiza kiri muri ibi no muri ibi biganiro nuko bigaragara ko abantu barimo gukora commitment yo gushyira mu ngiro yo gukoresha za conditions zihari. Nicyo ikintu nabivugaho kandi numva ko ibi byose birimo kuvugwa birashoboka kubera ko hari conditions ziriho rwose zituma bishoboka ahubwo tubyinjiremo vuba kandi tutagenda dufite hari igihe ujya mu bintu wumva ko wenda bitazashoboka ariko hari tugaragariza yuko iyi nzira tuyigiyemo bishoboka. Murakoze.
kugira ngo mukomplete aba bashakashatsi bakoze akazi kabo ko kwerekana ikibazo ko giteye dushatse twanavuga tuti merci beaucoup abantu bose batumiwe muri symposium nuko bafite aho bahuriye n'iki kibazo n'iyi problematique ni ukuvuga ngo twese tuve hano turisensibilize ko muri priorite zacu tugiye gushyiraho umuti w'ikibazo batweretse uko kimeze dufite ubushobozi hari hasigaye kumenya gusa nababwiye nti hari ibintu byinshi bidashoboka kubera ko tuba dusabwa data tuba dusabwa kwerekana